Coming up next, we'll be talking about how do healthcare and social care organizations work better together. This session is bringing together community coalitions, safety net providers, and health plans to tackle the systems level changes needed to support and sustain whole person health. Please join me in welcoming to the stage Heidi Arthur, Amie Parikh, Andy Mendenhall, Carol Huffman, Erica Coletti, and Maddie Abreu. Please welcome.
Now can you hear me? Hello everybody. So delightful to be with you. I'm Heidi Arthur and I'm with Health Management Associates, and I'm really pleased to introduce you all to the panel that's here today. But actually they're going to introduce themselves, and we're going to invite them to share a story about a person that was served by their organization or by their sector that really illustrates the services that they provide and their approach to care delivery. So Amie, we'll start with you.
Hello. Hi, I'm Amie Parikh. I am the CEO of Hudson Valley Care Coalition. We are a lead health home, a lead social care network, and we also have a behavioral health IPA. My story today is about 3 individuals that were served by the social care network early on when we were still trying to figure everything out. The first person actually became our lead navigator. Her name is Daria Williams. She is employed by HVCC now. She was approached by a navigator during her postpartum. So she had severe depression. She had hypertension. She had just given birth to, I think, her third child. No, second. She's on her third right now, her second child. And the way that she tells the story, the first time that she told her story was at a social care network summit that was held up in Albany. And I had tears in my eyes, and the impact that we made on her life, and the way that she was inspired to pay it forward for other individuals in the Hudson Valley. The other 2 individuals also, what I want to share about their story is a single mom of 3 children. 1 had passed away. So Angel is up in the sky in heaven watching all over her family. And what she said at the end of her story was she was able to stop worrying because she had food and she was able to take care of her children now. So that also was a very impactful story for the HVCC team to hear and the network to hear in the Hudson Valley. And the third was a gentleman who said, I can now grab my food and go to work and not eat unhealthy food. That he is on his way to lowering his hypertension to a manageable point and just eating nutritious food, because he didn't have cooking skills either. So now he's enrolled in cooking skills, we got him cooking supplies, but it was those 3 stories that lifted our social care network in the Hudson Valley and really made an impact on 3 individuals and their families.
That's beautiful. I'm Erica Coletti. I lead the Healthy Alliance Social Care Network lead entity. We cover 24 counties in upstate New York, from the capital region up to the North Country, the border of Canada, and over to Syracuse. Much of that is rural. About 21 out of the 24 counties is rural. We had one of our community members, actually, we contract with about 200 organizations, and one of the organizations is in a town called Watertown, which is way up north. And it's like about 3 or 4 hours away from Albany. And she went to Watertown. She was new to Watertown, and she was sleeping on couches of her friends. And she Watertown Urban Mission, which is one of the community-based organizations we work with. And they, she connected with one of the navigators there, and they had a conversation about her housing situation, and she's like, I didn't, just the realization of being homeless, like I'm homeless because it's not her couch. And she tells this story way more beautifully than I'm doing right now, but she was very inspiring, and she, through her journey, she just looks at this organization as they just grabbed her and like held her close. And she has since become a navigator, and the network was hired by them. And she is just has the best outlook, and she's always like, it might be raining now, but the sun will always come out. And so she's just beautiful.
Is this on now? Okay. So mine's going to be a little bit different of a story. I bring props so I can remember since I'm postmenopausal. This is my knitting needle and my yarn, and I'm from the payer space. My name is Huffman, and I build programs that wrap around the members for whole person health, because that's what I believe we all need to be doing in the future. One of the programs that I love, and the CEO here is Maya Parikh, so I'm going to talk about her for a minute, is May Health, which is a program that really enables the community doulas to be able to serve as part of the care team with an infrastructure, with technology, and with the ability to interact and, with the health plan members, with the patients, and really help them get the resources that they need from their community through, for example, the CDOs and the SCNs. This is a program that was enabled by Kathy Hochul because she had the foresight to create a doula benefit in New York. So we're very fortunate that we had the state to really be driving this. The state listened to, when I was at a health plan in New York City, they listened to our Think and Do tank, where we went to the state and we said, we think that doulas should be paid a little bit more. We think there should be these many benefits, these many visits. And we went through a lot of the details, and then we met with the state. The state listened to us, and the benefit was rolled out April 2025. We enabled a stronger benefit by bringing on May Health, who supports the doulas. And so when I look at the healthcare system, I like concrete programs that really do make a difference. I like the think and do, and I like to make sure that we're not just talking, that we're actually putting programs together that demonstrate that we really can knit together the healthcare system together for whole person health.
Hi, I am Madeline Abreu. You can call me Maddie. So it's great that she was right before me, because I'm that organization that makes the connections. I'm a community-based organization located in, I do service Bronx, Westchester, as well as Rockland, in some of the Hudson Valley areas as well. So my story, my member is a mother who has a child in a wheelchair. He has disability. She had brain surgery, but she has to carry him every day. I get emotional. She has to carry him every day from the front of the building into the building, because there's not a ramp in the building, and because we're in Hudson Valley, the OPWDD services sometimes are not as accessible, or they're just not aware of them. So what we do as a community-based organization is make those connections. So now we got a dwelling assessment. We're in the process of building that ramp, allowing her to take care of herself as much as she takes care of her son. And then also providing food for the family so she doesn't have to work as much and she can spend some more time with him. And then the final step on that is also talking or having conversations with her and understanding to see if maybe there's some anxiety or mental a referral that needs to happen to some of the providers in the community. That's my story.
Thank you so much, Maddie. Good afternoon, everybody. My name is Amie Mendenhall, and I'm a practicing physician and honored to represent the work of Central City Concern from Portland, Oregon, where we operate a large healthcare for the homeless federally qualified health center system integrated with a 2,400 unit affordable housing continuum and a supportive employment continuum. And we have two golden threads. The first is helping people who are in our permanent housing portfolio stay permanently housed. And then we have another golden thread that I want to talk about, and that is helping people from the continuum of being houseless with an active substance use disorder get into housing, get stabilized after withdrawal management, receive outpatient behavioral health services, and over a period of several months then conduct workforce reentry. So a good friend and colleague of mine, I'll change his name, is Joe, and Joe joined us 7 years ago, has a master's degree, was an educator, had a physical injury, developed a problem with pills, found himself living in his car in active addiction for more than 3 years. And the last 7 years has been in recovery and is now a program director within our organization, responsible for training peers, training housing case managers, and continuing to spread the message of recovery and resiliency through our work.
These are beautiful stories. Thank you all so much. I always reminded when I go to panels and I ask people to start with stories, I have to remember that I get kind of choked up. It's a little hard, and then it comes back to me and I have to keep talking. But let's start talking about equitable access. When we talk about aligning social care, the community-based organizations, those peers, the community health workforce is so vital to ensuring access and reaching those folks who are otherwise perhaps not served by the traditional clinical care system. So Maddie, I want to bring it to you to start. You founded Gratis Community Care specifically to respond to your community's needs. Can you tell us what makes the community services that your CHWs provide so unique?
Absolutely, thank you. So I'm a human. I'm a daughter. I'm a mom, and as I went out to the community to do Medicare, I was a Medicare broker. I found that the state members just kept trying to get social management translation services. They wanted me to recommend a provider because something was going on. And sometimes they just needed us to read a letter for them because they couldn't, not write and read, but they couldn't comprehend what was written in the paperwork. So I was able to find that program culturally driven because I do work a lot with the Spanish and Asian community, low-income individuals that are immigrants and that are coming in and they do not understand the system. So the system was built for individuals that have a certain level of understanding already, and as you come in from different parts of the world, there is a gap between what the programs were providing and the community, and that was the niche that I came in and found, and I am servicing them.
Thank you so much. Carol, I'm going to flip it to you and ask, CBOs, like we're hearing, they're not like other providers, which is why they are so effective in reaching the populations that have traditionally not been well served. I'm curious, how do you see the future of managed care, embracing CBOs and the inclusion of community-based workforce to really promote wellness and well-being across the human service ecosystem? How do you see that happening beyond the waivers?
So here's my giraffe, and what I'm going to ask everybody in this room is to be the giraffe and stick your neck out. So it's really important for us to all do that. Stick your neck out and work together. So the future has to be that all the stakeholders work together. Right now, the way healthcare works is it's one hand clapping, and the right people are not in the room working together to take out the low value care and replace it with high value care. And what I mean by low value care is all the extra administration, all the extra chasing around of phone calls, all the extra silos that we don't need to have anymore because we've got smart technology that we can install together. We can get in a room and we can have conversations and we can work through this together. But if we continue on in the traditional sense where we allow people in our organizations or in our communities to stay siloed, it will not change. But we have the opportunity now to sit down and work together and really make a positive change happen.
Thank you. Amie, Hudson Valley Care Coalition has a network of over 160 community-based organizations in your network. I wonder if you can talk with us about what this kind of CBO network engagement has required. What did it take to build that trust, pull that network together, recruit, engage, and retain them?
It's a very big lift. So we started our journey back in 2022. As I mentioned, we're a lead health home. So we had a network of 25 community-based organizations that ran the gamut of hospitals, federally qualified health centers, behavioral health, and also organizations that have a long history of serving the LGBTQA communities. With that foundation, we merged with a behavioral health independent practice association. So to answer your question, like when we were trying to build this social care network, we had the trust of 54 agencies right off the bat, because we have been working with them. It was the larger community that we had to really outreach and bring in, as Zach said in a previous panel, like really include those organizations that the health home care managers were relying on to provide services and partner with the health home care coordination program to do the food, to work with housing, to work with transportation. So those are the organizations that we had to build that trust with. I was telling Maddie that since 2018, we have been trying to work with the Haitian community in Rockland, and we were not successful. We became successful through the social care network, through Maddie, and other organizations where we used community leaders. We also, a team member of mine, Brianna Pierre, also began to reach out to the smaller organizations that our care managers relied upon to try to lift that partnership to an administrative level instead of a care manager to care manager level. So once those care managers leave, that trust, that relationship is gone. So we use quite a few different strategies, like we use leaders in the community to broker relationships with us. We spent a lot of time from 2022 all the way through putting together our application, being very transparent about our model, being very transparent in, we come to this work with a co-design methodology. So we don't go in our offices and design these models. We go with our community-based organizations, with our hospital networks, with our county governments, and say, how can we work together to make sure that the social care network, to make sure that behavioral health services are being delivered within the social care network model. And then within the behavioral health model, making sure that people are connected to health-related social needs. Vice versa, in our physical health, same thing. That model is a very much like a roundabout, whole person care that we are slowly, baby step by baby step by baby step, building in the Hudson Valley area.
Thank you, Amie. And Eric, I want to bring it to you. You have a massive geography. How do you balance the need to standardize the services that people are getting from Healthy Alliance while also allowing for that sort of local flexibility that's necessary to meet the needs of folks in rural communities?
Okay, now you can hear me. So when you think about shifting to doing Medicaid billable services in the CBO environment, there are just table stakes. Like you have to follow guardrails, you have to do certain, there are requirements. And so what we try to do as an organization is really like provide that very clear roadmap, education, training, support, reviews, co-location, like all the things that we can do because we want to minimize the risk on the community-based organizations of providing something and billing for something clawed back or some issue later. So we're taking that on. From the customized, the big piece of that though is like how those things come together is where it's local. And so you bring, we have been working very collaboratively, like on the ground with organizational leaders, and we have multiple get-togethers. We call them like regional work groups, where we also help support by sharing data and what's happening. And then we have leaders who, from the different sectors or who provide an end-to-end of the services, come together and help design the workflows and how it's going to work between them. So that's not just CBOs, it's the health systems, it's behavioral health providers, it's government. So it's really at the community level, and so that's where we try to find that line.
That's so great. So over and over, I'm reminded that the strength of any partnership is really determined by the level of trust. And it requires that people trust their service providers, providers need to trust their payers, collaborating partners need to trust each other, and nothing destabilizes trust faster than access barriers, glitches with administrative bureaucracy, not getting paid for services you've provided, all the things that can be such a challenge in aligning social and clinical care. Andy, I want to ask you, because I feel like you might have the answer that many people are looking for. Your model is a sort of whatever it takes approach, and you have blended and braided funding in order to wrap services around the population that you provide care for. Can you tell us, how do you do that? It's still a secret. This is how he keeps it to himself. Does this work?
There we go. It's on and off. I'm going to project.
Use a different one. Maybe use
This
use
one?
Maddie's.
Oh, okay, this one's on now.
Here we go. All right, third one's the charm. It was actually the first one, right? So Heidi, thank you for the question. Braided funding. We have not mastered this. So take what I say with a grain of salt. We're happy to chat with you about what we're doing, and we're certainly on a journey. Because we operate within an FQHC space, we are richly rewarded on a fee-for-service model, but we know that that's not sustainable long-term and really need to move in the direction of value-based payment, particularly for primary care services. However, we are able to utilize the revenue generation within the healthcare parts of our organization to cover gaps and deficits that have been long-standing and chronic with respect to housing and supportive housing funding. It is reinvestment back in the community. We know that it's an important part of the process, and it's also not the long game. We definitely see the need to do two things. The first is bringing parts of our supportive housing programs, meaning the staff who are actually doing things like peer-based services, housing case management, and bring them into the FQHC. So we're in the midst of transforming that workforce and elevating their ability to drive revenue in a fee-for-service manner. But the long game, the way that we see it ultimately, is to move in the direction of a comprehensive social housing benefit. And we're moving in the direction of gathering the data in terms of shared cost savings, return on investment, and most importantly, the sustainability that is needed in order to scale deeply affordable and affordable housing, which has really, in our region, come to a standstill because of the challenges in affordable housing operation, holding so much of the unmet social health needs of the folks that reside within. So we're in the midst of that journey, and I'm really grateful, having been with the organization for 9 years, of all the leaders that have come before me in terms of setting the stage for us to create success over the next several years.
And that, to go back to the panel before and their first question, what keeps me up at night is really trying to figure out how organizations like Maddie's, which are really small CBOs, because we have large CBOs. Like we have CBOs that have 50, 70, $85 million budgets, right? We're talking about the CBOs that are between 5 million and let's put it a little bit higher, 15 million. How are we gonna really maintain their connection into the HVCC network, making sure that they get paid adequately for the work that they do, and also just like live a sustainable life, like the way that you're trying to do, Maddie. So that's what keeps me up at night. And the braided funding, we started off with like America, like the whole duplication of services and braided funding. Like we were having those conversations in 2024, early 2025, and then we just got really like into the operations where that conversation is kind of at the back burner. And then I know, like Eric and I have been talking, like it's got to go push up now. It's really got to push up because I have concerns because those CBOs are the ones that are going to make this network successful. Not that others don't matter, but it's those smaller CBOs that we need to maintain in our network.
Yeah, Carol, I think this is a great opening for you to talk about how do you see the future for the health-related social needs services going forward?
So you know I have to have a prop because I just don't have a good memory. But this is Barbie, and she has a pump because she's a diabetic. This reminds me. So one of the, and if anyone would like this to take home with them if they have anyone in their life who is a child that has diabetes. One of the programs that a health plan can do now, and one that we're putting in with Westchester Medical Center, which again shows the knitting together of the healthcare system, the integration of all the stakeholders, is something called Wildflower Health. And Westchester Medical Center, which is a medical center, has a health center for health equity, has a medical school, you know, just has, it's such a wonderful system, is putting in an app, a technology with Wildflower Health that is white labeled to them, even though it's paid for by a health plan, enabled by a health plan, that they can use for all of their patients regardless what health plan. And until we start to think about it that way, we're not going to be able to help our communities because everybody's still going to be in the silos. And what this app is able to do is to have the resources at the moms and dads and parent partners' fingertips as they're going through a maternity journey in a new way that really surrounds them and wraps around them for whole person health, because it will allow them to be able to even understand if they're eligible for the services in an SCN. What are they? How many of us just, go through life, we don't even know what we could have, we don't know what to ask for. But this will be able to serve it up, and the care coordinators at the hospital and through the humans that support inside the app will be able to help that parent through the whole journey postpartum, as well as, early childhood. And until we start thinking differently about how we could solve these problems, we're not going to. And that's again where I get back to sticking your neck out. Like, sometimes I'm a giraffe and I stick my neck out and sometimes it gets chopped off, but sometimes it works. And so I just really encourage you guys to do like what Blooming Health is doing and thinking differently about how could they support this whole journey.
Yeah, Maddie, I want to turn it to you. What tools are your CHWs using now, and what's on your wish list for the technologists in the room for your future state service?
So a self-created AI system. I created a CRM system with AI, very basic because of HIPAA. And they've been using that to be able to follow up, to be able to automation is a big deal, reminders. This takes a lot of time in order for us to be able to help more, because sometimes it is just a call for a follow-up and just to make sure everything went well and that they got the delivery of whatever it is, whatever service we're providing. So just those reminders are important. Sometimes we have follow-up days. What would I like to see? The same, but a more sophisticated system where we can also track and then give back to HVCC. in regards to the data that they need to help me stay alive. So it's kind of like a two-way avenue, and that's not something right now that I would say we have except for the platform, the Unite Us platform. So having a better CRM system that can track and have a better dashboard for tracking purposes, as well as for follow-ups and automation of the system.
Wonderful. Let's take it to Erica. What's on your wish list for technology? What would make your life easier?
Oh boy, this is a long one. No, I think for us, and it was shared on one of the other panels too, is really having that longitudinal view around data and having things fed to us. Like I love the Blooming Health demo. Really getting ahead of people's challenges and issues instead of being so reactionary. I think we're still reactionary. And really, again, having folks stick their neck out, do something different, but let's really actually become proactive.
And Amie, same question to you. What strategies, though, have you found work best within your CBO and provider network for HVCC?
I think we're still trying to figure that out, to be completely honest and transparent. So we have no real-time data. The one that Lima, that was just phenomenal in the way that, if it needs to be, if it's critical, if it's high, if it's medium, it's really guiding the navigator of what needs to happen next. And I've been asking for that since I started with the health home in 2016. Because if we think about our navigators and if we think about our care managers, they are the least paid, but they must know about the entire healthcare system, right? So our health home care managers, our members could have diabetes, they could have hypertension, they have serious mental illness, they have substance use. So our care managers are required to know how to navigate all of that, right? On a $45,000 to $50,000 salary. So what Blooming is doing is really creating that co-pilot for navigators and care managers. And so I think that's amazing. I think what we're doing now is data sharing, right? So my team member Carlos goes into our data warehouse, pulls data out, and then sends data to the CBOs and says, okay, so these are the number of screens that you've done, and these are the number of eligibility assessments that you've done, or during our chart reviews, this is where you land doing a chart review. It's not real time. It's not helping the person who is frontline. And those that know me, yes, I'm an advocate for the member, but I am a strong advocate for those frontline providers, those navigators and those care managers that our members trust and they tell their life stories to. And we need to give them better tools to provide those services and practice at the top of their license instead of spending 80% of their time documenting in an EHR.
Absolutely. Andy, what policy or tactical changes would improve your organization's capacity for streamlined, more efficient team-based care?
Heidi, from a tactics perspective, I want to elevate what Erica and Amie noted, and also was mentioned by Pamela in the morning session, and that's a unified care plan. One care plan to rule them all. At CCC, we are still siloed with a lovely Epic platform, Ocean Epic in our region, and we use housing case management software, Apricot. From a tactical perspective, the value will be created by maximizing top of license practice of the human beings doing the work, and that's why I find the Blooming Health platform so compelling. And the demo, I agree, was just fantastic. So those are the tactics from a policy perspective. I think it's really important for us to balance and continue to lean in to understand where do we balance and find balance in terms of privacy and privacy around health data. And I feel particularly sensitive about that as an agency that does a lot of behavioral health and substance use disorder services. But more and more, as I have grown longer in the tooth over time, I just continue to see our policy around privacy being more obstructionistic and getting in the way and causing more than the fear-based harms that those policies have been designed to potentially prevent. So I think we should continue to lean in. I think it's going to require some focused leadership voices in that space to affect change.
If I could just add to that, I do think that is a big deal. I think there's some, consumer advocacy out there around privacy, but they're not talking to these members, these community members who get really tired, and again, echoing some of the panelists earlier, get really tired of telling their stories over and over and over again, instead of having that visibility. Of course, there's a, opportunity to share your own health, but let's cut through that and not make this such a traumatic experience for them.
I know we only have a few minutes left, and so I want to do a quick lightning round, imagining the future state. Say we reached the nirvana five years from now. Let's give ourselves 5 years to get there. We're there, and social health inclusion has effectively occurred. What is one thing that we're doing now that feels like an innovation, but it's going to be standard practice in the future? Amie, I'll start with you and just take it down.
I'm happy to, I'll try to jump in. You guys will do better than this, but I think if with all of that in place, that we can access, or people can access us before, we can find people before the need starts to elevate, and that it's really truly proactive, predictive, and we can actually have the results of a flourishing community. Again, we're reactionary, we're trying to talk a lot about predictive analytics and so forth. It's a real thing, it's there, but we need to see it in practice.
There, one again. Very briefly, I see a future where housing with supportive services is a durably funded part of a comprehensive social benefit for many different population segments. Individuals with severe pervasive mental illness, families in poverty, aging adults, just to name a few.
I see true connectivity, a true resource center for a community-based organization. I think Amie, one of the earlier panelists talked about the system being saturated with too many services. Not everywhere, in the Hudson Valley, but those that are there, a true connection, because we're not successful today about connecting the community with those resources, and it's very important that we connect them and that we all talk to each other and wrap that all around each other, as you said, Carol.
So I think that we're working as a team, and the data and the AI will have created the pathways that allow us to do that.
Excellent.
Yeah, so I did write this down because I really thought about this question, and I say this with emphasis, that an integrated system recognizes improving health. It requires investment for social care and behavioral health drivers. Behavioral health gets left behind time and time again, but we need the same level of operational discipline and infrastructure historically reserved for clinical care. Because a core part of our network is behavioral health, I really, really emphasize the integration not only of social care, but it's social care, behavioral health, and clinical care.
And can I just add to that, because that's super important. And on top of that too, I would say we need to fix the financial models and how there's segregation between different lines of business, and what your insurance card says, and it makes this incredibly burdensome where we could be spending this time and these resources on actual care.
Amen. Amen. And back to the earlier point, I think it was Zach Hennessy who was saying that we have to start appropriately financing the social, human, and behavioral health care delivery system with equity and real intentionality for whole person regardless of where a person lives, who they are. So thank you all so much. I see we have 16 seconds left.
Thank you.